So ankle injuries are among the most common injuries presenting to primary care offices and emergency departments. There's different types of ankle sprains. Here we're not going to talk about ankle sprains in children. It's going to be a little bit of a different ball game because children aren't fully skeletally developed yet. So that's why we're going to just talk about adults here. We're going to talk about standard adult ankle sprain, which means the ligament is affected. So the ligament can be stretched, it can be partially ruptured, or it can be completely ruptured. And it can involve one or more ligaments in the ankle. But most ankle sprains are partial rupture, full rupture, or a stretching sprain. Usually it's also a lateral ankle sprain, so on the side. And mostly this happens during sports. So this can also happen in different scenarios where someone doesn't have their balance for whatever reason due to lack of vision, age, or possibly alcohol or drugs. So the incidence of ankle sprain is higher in adult females than adult males, and also higher in children and adolescents than adults, which makes sense because they play more of the organized sports. So systematic reviews and literature reviews have revealed that there's a number of intrinsic or internal and extrinsic or outside the person risk factors. Intrinsic has to do with so if they have limited range of motion or not as much dorsiflexion, if they have reduced proprioception. So the main environmental risk factor or extrinsic factor is the type of sport played. So indoor court sports tend to be number one. So basketball, squash, indoor volleyball, things like that. Also field sports and climbing have a good, pretty high rate of lateral ankle sprains. Playing soccer on natural grass rather than turf can increase your risk of a lateral ankle sprain. And playing a defender on the team also increases your risk. So the people who are blocking the goalie kind of a thing. Some modifiable risk factors should be identified and addressed as part of any prevention or rehabilitation program in order to decrease the risk of recurrent injury. So how can we prevent this from happening again? It has to do with inversion of the plantar flexed foot. So this causes damage to the lateral ligament complex of the ankle. This ligament complex consists of the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. So one or all of these ligaments is either stretched or totally ruptured in the majority of ankle sprains. Stronger forces lead to combined ruptures of the anterior talofibular ligament and the calcaneofibular ligament, which can result in significant ankle joint instability. Isolated injury of the calcaneofibular ligament is uncommon. Such injuries, while uncommon, are more debilitating and more commonly associated with significant nerve injury. A medial ankle sprain has to do with the medial deltoid ligament complex. And this is the strongest ankle ligament, and it's not really injured very frequently. Basically, forced eversion of the ankle can cause damage to this structure, but more commonly results in an avulsion fracture of the medial malleolus because of the strength of the deltoid ligament. So syndesmotic sprain, or a high ankle sprain, has to do with dorsiflexion and or eversion of the ankle. This may cause a sprain of syndesmotic structures, which include the anterior tibial-fibular, posterior tibial-fibular, and the transverse tibial-fibular ligaments. So there's a lot of ligaments in there, and the interosseous membrane can also be injured. These structures are critical to ankle stability, and if you injure the syndesmotic ligament, this is a big deal because it can contribute to chronic ankle instability, and it's more likely to result in recurrent ankle sprain and the formation of heterotopic ossification. So ankle sprains have traditionally been classified based on clinical signs and functional loss from grade 1 to grade 3. So a higher grade sprain involves more severe injuries to the ligament, and the time for healing is not always proportional to the grade of the sprain. Evaluation of an injured ankle requires a careful history. It is important to determine some things. So if it's a grade 1 sprain, that would occur from mild stretching of a ligament with microscopic tears. Patients will often have mild swelling and tenderness. There's no real joint instability on examination, and the patient is able to bear weight and ambulate with minimal pain. Due to their benign nature, these injuries are not frequently seen in the office. A grade 2 ankle sprain is more severe injury involving an incomplete tear of a ligament. Patients have moderate pain, swelling, tenderness, and ecchymosis or bruising. There may be mild to moderate joint instability on exam with some restriction of the range of motion and loss of function. Weight bearing and ambulation will be painful. A grade 3 sprain involves a complete tear of a ligament. Patients have severe pain, swelling, tenderness, and ecchymosis. There is significant mechanical instability on exam and significant loss of function and motion. You will feel this when you palpate. They will also let you know. Patients are unable to bear any weight or ambulate at all. The mechanism of injury in order to direct. So you need to know the mechanism of injury also. How did it happen? The physical exam of the ankle includes inspecting it, palpating it, and then determining if they can bear weight. Can they walk? If you think it's a certain ligament or you have a feeling it's a lateral where it's located, you can use specific tests. The squeeze test consists of a compression of the fibula against the tibia at mid-calf level. This maneuver elicits pain in the region of the anterior tibulofibular ligament, anterior to the lateral malleolus and proximal to the ankle joint. The external rotation stress test. This test can help identify if a syndesmotic strain has occurred. The clinician stabilizes the leg proximal to the ankle joint while grasping the plantar aspect of the foot and rotating the foot externally relative to the tibia. The test is positive if pain is elicited in the region of the anterior tibulofibular ligament. So if you get pain in this area, you will know. You will also need to know whether or not the patient can walk after the injury. If they can't, there's a chance of fracture, so keep that in mind. Whether or not the ankle had been previously injured, as people who sprain ankles are most likely to re-injure the same ankle. A study in basketball players found repeat ankle injuries almost 5 times as likely as primary injuries. So look for swelling and bruising. Palpate the entire fibula. The Thompson test should be performed if any tenderness or a tissue deficit is detected while palpating the Achilles tendon. The anterior draw test detects anterior displacement of the talus on the tibia. If the anterior talofibular lateral ligament is torn by an inversion stress, the talus will sublux anteriorly and laterally out of the mortise. The test is performed with the patient's foot in the neutral position, slightly anterior flexed and inverted. The lower leg is stabilized by the examiner. The test is more sensitive and specific when performed between 4 to 5 days after an acute ankle sprain and is helpful in the evaluation of chronic ankle instability. The Taylor tilt test detects excessive ankle inversion. If the ligamentous tear extends posteriorly into the calcaneofibular portion of the lateral ligament, the lateral ankle is unstable and Taylor tilt occurs. With the ankle in the neutral position, gentle inversion force is applied to the affected ankle, and the degree of inversion is observed and compared with the uninjured side. As with the anterior drawer test, this maneuver is of limited usefulness in the acute injury because pain, swelling, muscle spasm will prevent you from being able to do this. A deferred examination may improve the diagnosis of ligamentous injuries and instability. So we're going to put this off due to the pain and swelling and issues. A study of 160 consecutive patients with inversion injuries found that performing a physical examination 5 days after the injury improved the accuracy of diagnosis ligament rupture. You're going to get a better assessment if you wait. Plus, you're going to save them a lot of pain. Tenderness of the distal tibia or fibula may represent a fracture associated with inversion or eversion injuries. Effusion and pain on palpation of the talocrural joint may suggest a fracture of the osteochondral talar dome. Check for pain on gentle passive inversion and eversion of the ankle. In lateral ankle sprains, pain is increased with forced ankle inversion, while the pain of a medial or deltoid ligament sprain is accentuated by eversion of the ankle. Perform specific examination maneuvers as described, including the squeeze test, and use the external rotation stress test, the anterior draw test, and the talar tilt test. Although these maneuvers can be helpful, they have not been rigorously studied. If there is no swelling or ecchymosis on physical exam, these maneuvers don't elicit pain, and the Ottawa ankle criteria for imaging are not met, there is unlikely to be any structural damage, which is great. As an example, patients with diminished peripheral sensation, such as diabetes or intoxicated people, might need radiographs regardless of the Ottawa outcome. And then we have imaging. What kind of diagnostic imaging are we going to use? Malleolar fractures, distal tibia fractures, talar dome fractures, and syndesmosis separation can be diagnosed with a plain radiograph, so an X-ray. If indicated, anterior, posterior, lateral, and Mortise radiographs should be obtained. Stress radiography, or obtaining plain films while performing a talar tilt or anterior draw stress maneuver, is sometimes considered. However, it is rarely, if ever, clinically helpful. The setting of acute injury, magnetic resonance imaging, or MRI, has no advantage over plain X-rays or radiographs. However, an MRI should be considered in ankle sprains that remain painful after 6 to 8 weeks of standard therapy. MRI can detect talar dome fractures and can confirm suspected syndesmosis or other soft tissue injuries. Remember, a missed fracture can be a major court case for you, so you don't want to miss an actual fracture. If you have any suspicion, you're going to want to take that radiograph. Immediate therapy for a sprained ankle includes limiting pain and swelling to maintain the range of motion. So rest, ice, compression, and elevation. This is commonly recommended for the first 2 to 3 days. Although data on the effectiveness of rice alone are lacking, NSAIDs, or non-steroidal anti-inflammatory drugs, can be used for pain relief as well as this decreases inflammation. Both oral and topical NSAIDs are more effective than a placebo. These include ibuprofen, ketoprofen, diclofenac, and sometimes patches. Rest is achieved by limiting weight bearing and patients using crutches until they can walk with a normal gait. Cryotherapy can be ice or cold water immersion for about 15 to 20 minutes every 2 to 3 hours in the first 48 hours, or until swelling is improved, whichever comes first. Compression with an elastic band to minimize swelling should be applied early. The injured ankle should be kept elevated above the level of the heart to further alleviate. There are no studies comparing topical NSAIDs and oral NSAIDs. Remember, take care with NSAIDs because they are associated with complications and they suppress the healing process. Exercise is the mainstay of recovery, as in many musculoskeletal injuries. Range of motion exercises, including plantar flexation, so flexing your foot, dorsiflexion, and foot circles, should be started early once the acute pain and swelling subside. This will maintain range of motion. The intensity of rehabilitation is increased gradually. Ankle sprains or braces can limit the extremes of joint motion. So it can also help for early weight bearing while protecting against re-injury. The treatment of severe grade 3 ankle sprains is controversial. A brief period of immobilization may be helpful in some instances. Patients with mild grade 1 ankle sprains do most definitely not require immobilization. Treatment with an elastic wrap, such as an ACE wrap, for a few days following the injury is sufficient. Patients with moderate grade 2 sprains may need sustained support following their injury. Combination of an elastic wrap and an air cast or similar splint can be very, very sufficient for a few weeks after. Can be very, very helpful. Ankle support in patients with mild or moderate sprains should not interfere with early rehabilitation. The appropriate type and duration of immobilization in patients with severe ankle sprains remains unclear. For a grade 3 sprain, studies suggest that early mobilization with a stabilizing orthosis may result in earlier resumption of work and sports as compared with simple immobilization. Air cast brace, Bledsoe immobilization boot, or tubular compression bandage can all be very helpful. Assessment at 3 months using a validated score for the ankle function found the greatest improvements in the cast group. Alternatively, a comparable period of strict non-weight bearing and immobilization using a combination of an air cast splint and an elastic wrap can be used. Early functional rehabilitation can be started once immobilization is discontinued. For patients treated without casting, the importance of compliance with treatment, maintaining the non-weight bearing status, is very important. So for rehabilitation, exercises have to do with functional rehabilitation. So we want to aid them in return to activity while preventing chronic instability and recurrent injuries. Early functional rehabilitation begins with exercises for mobility, such as stretches and foot circles, alphabet exercises, and strength, plantar flexion, dorsiflexion, and inversion, eversion, toe curls, and marble pickups, heel walks and toe walks. Circular wobble board and walking on different and unstable surfaces can be helpful. Progressing from a walk to jog, from a jog to a run, from a run to a sprint with a change of direction, are how we're going to kind of stage the recovery. This should all start as soon as the swelling and initial pain has subsided sufficiently to allow the patient to do simple exercises. This rehabilitation needs to continue until the patient has returned to pain-free, full activity. The rehabilitation program should take several weeks in order for the ankle to strengthen and to limit the chance of re-injury. In a study of active duty Marines with grade 2 ankle sprains, those undergoing a structured rehabilitation program returned to duty up to several months earlier than those without rehabilitation. Some patients may benefit with additional support, so splints and braces during functional rehabilitation, elastic bandages, helping to limit swelling in this way. Tape or maybe a semi-rigid brace is also a good idea. Surgical repair of a ruptured ankle ligament is sometimes considered in patients with ankle sprains, depending on the severity and the pain level and the location and their activity level. Given costs and operative risks, it is unlikely that most patients with mild or moderate ankle sprains will be treated surgically. It may be reasonable to consider surgery in some patients with severe sprains who are engaged in professional sports or other activities that are likely to impose repeated large stresses on the ankle joint. Some other interventions include low-level laser, hyperbaric oxygen therapy, and platelet-rich therapies. Most ankle sprains recover fully with non-operative treatment, but as many as 30% of patients develop some chronic ankle instability, which can present as a recurrent ankle sprain. Return to work. The extent of injury determines the time required for healing and the corresponding ability to return to sport and work. Appropriate immobilization and rehabilitation can decrease this period, depending upon pain and the severity of injury. Most people with a lateral ankle sprain that does not involve complete disruption of ligaments can return to work in about 2 weeks. Following surgery, obviously we're going to need full recovery time, and it's going to be at the discretion of the surgeon, as well as on crutches for approximately 2 weeks or longer. 12 to 16 weeks following surgery may be required before it is possible to return to full activities and for a physically demanding job. It's important to monitor for neurovascular compromise when we're using any type of wraps or braces or casts. Patients with neurovascular compromise, such as decreased sensation, motion, or circulation, will require emergency evaluation. Ankle ligaments provide mechanical stability as well as proprioceptive information and directed motion for the joint. Acute ankle sprains can result in lost days of work or inability to participate in sports. A meta-analysis of 31 studies assessed that the outcome of patients with acute ankle sprains are similar. Prevention. Options for prevention has to do with support if needed, physical training sufficient to keep up with the demands of their job or sport, lace-up supports, orthosis, high-top shoes, taping. Physical training interventions may include strengthening, proprioceptive ankle training, and using a wobble board. It's important to minimize pain in the recovery time while minimizing medications and bracing as needed. Recover for the appropriate amount of time so that when you do return, you don't re-injure the area. Very, very important.